Thank you, Anne. Good afternoon to everybody. Maybe good morning. Sorry. I don't know what time is it exactly worldwide, but different times. Thank you for inviting me to comment on this difficult topic of medical shutdowns. Of course, the problem is not only the problem of the, the problem is not only the problem of the pandemic of the COVID. We have medical shutdown in various conditions, environmental disasters, wars, and not least probably also in a way isolated and deprived areas worldwide that have little or no medical support. What makes maybe more specific the COVID crisis is the idea of the quarantine and the mandatory isolation of the population for a long period of time. We shall come back on that a little bit later. So if we want to understand very quickly what occurs with medical shutdown, easy to understand, we have an interruption of the routine care for chronic patients. In practice, the healthcare system cannot sustain the uncontrolled outbreak. And especially in the COVID, the surge in patients requiring ICU admission has been totally overwhelming all countries. As I said before, the cities and countries are quarantined and government have instituted stronger containment measures, including strict self-isolation measures, and there are major problems with emergencies. Well, it's just a summary to say that the medical access is made difficult or impossible. Doctors and nurses are missing. This is one of the characteristics of any shutdown. And this is due to a double mechanism. One is the number of demand, which is growing very quickly. And the other point is the growing lack of professional in the case of COVID infected by the disease, but the same with the war for other reasons. What we know from the literature is that the time scale is critical. After 2 weeks, the problem starts to become really big problems. After 3 months, the problems turns to really very, very complex problems with a lot of consequences for the medical for the medical consequences, but also for the political consequences. If we just try to capture the size of the problem, we have a number of visits to ambulatory care which declined by nearly 60%. This is shown on this picture from the Commonwealth Fund, but similar results have been obtained in many, many countries. So it's probably an average 60% of visits to ambulatory care disappearing. Another point is that we now have an estimate of 10% of additional collateral deaths of severe chronic and cancer non-COVID patients after 3 months of shutdown. And again, is a results that comes from different sources. But very recently, there were some papers in France and in UK telling that at least 30 to 40,000 people having a cancer have stopped any care during 3 months and are now in extreme danger for the purpose of their disease. Of course, this is also a problem of providers that are deferring elective and preventive visits, not just cancer, and this is true for all annual physicals. When possible, and this is the very core of this meeting, they are converting in-person visits to telemedicine visits, and that is good. But it is true also that patients are avoiding visits because they do not want to leave their home and risk exposure. And also influencing both provider and patient behavior are the evolving local and state recommendations restricting travel and non-essential services. If I just comment on the quarantine, the quarantine was introduced a long time ago in 12th century, but with Black Death, with leprosy, with probably also, certainly with plague. And recently we had a series of quarantine, also small quarantines or limited quarantines in China and Canada in 2003 with the SARS, and in many villages with the Ebola in Africa. And we have a fairly large literature on the results of the quarantine, and it's a dramatic impact of medical shutdown for mental diseases. There's a lot of people really in trouble, and of course the more exposed people are the older, but also we see that the people age 18 to 30 are overexposed to social media and tend to be more impacted at mental level by the quarantine. So and migrant also, the poor people. So we are in a situation where the shutdown is really creating a lot of problems for the population. Of course, we have the whole problems. When we open the shutdown, the crisis highlights a number of inherent weaknesses in existing healthcare system. If you have a shortage in doctors and nurses before the pandemic or before the problem, of course, that will become a huge problem with the pandemic. And also, we have a series of new problems coming. I suspect that these problems have been developed in many talks before, but it's quite important to say again that in most countries, we have terrible problems with these essential resources needed to tackle the pandemic, with the lack of respirators. So the shutdown is not just a human shutdown, it's also a technical shutdown. We have, as I said before, clinical staff becoming infected, resulting in periods of quarantine, some clinical staff paying the highest possible price, the loss of their life. We had in many countries figures about 15 to 20% of the professionals off during a period of time because they had the COVID, or they had the suspicion of problems. They could be off for 1 day or for 2 days, for 15 days or to 3 months. But the accumulation of people off was really terrible for the shutdown, and increasing very quickly the importance of medical shutdown. We have growing patient emotional problems associated with this crisis. And just to say that it's quite interesting to see, we have several now reports from Italy with the first COVID patients they had, and the crisis during the first, second, and week. And they say very clearly that they had terrible problems with patients willing to go to the hospital. And we have similar results from Asia, from Chinese paper and from other countries in Asia, telling that people are so emotional that they come and make an additional problem for the hospitals and for doctors because they fear having the COVID. Of course, we have new form of stress for doctors, and here we are introducing the solution and the limitation of the solution, because nonverbal communication, which are at the core of the telehealth, or most of the telehealth as it was used during the COVID, as well as physical examination, are essential tools to practice. The crisis imposed to make decisions without seeing the patient, and sometimes even without knowing him or her, and that has turned to terrible anxiety for doctors. And last but not least, everybody knows that there is a terrible uncertainty of the situation, Internet, and that's part of the risk in the medical shutdown. Very little knowledge about the disease caused by the virus, and the professionals as well as patients were unable to distinguish accurately clinically between those with a common cold or bronchitis and those with a case of COVID. And no idea how long this pandemic and the economic and social crisis will last. It will last, and this is always true. So it's really a big difficulty in managing such a situation. Sorry. I'm sorry. Okay. If we turn to the coping strategies for managing the situation, the first point worldwide is really the demonstration of the medical profession's power to adapt, evolve, and thrive, even in these times of unprecedented crisis. There's an incredible solidarity and creativity, and the hospital reorganizing at an impressive pace by creating new wards for infectious disease and intensive care, and that is true in all countries, including the poorer. The family medicine also is put at the center of the healthcare system, even among countries with a healthcare system that traditionally has been hospital-centered. And that is also very important because we see that in such a shutdown episode, family medicine is very central. That's the level for triage, that's the level for giving care and protecting people who are not only patients with disease like the COVID, but also patients that are very anxious, that are isolated, that are in situation where the domestic violence is increasing. And we had terrible figures about domestic violence during this period of shutdown. So the family medicine and every solution that makes people listening to problems at home are extremely valuable in this situation. Of course, national coordination centers have been established. It's true also that the social media have been really contributive to increase the emotion, but to share the emotion and give people some solutions or orient people for some solutions. There's a lot of wrong information on social medias, but there's also some important mechanism for using this social media as tools for breaking the shutdown. It was also a good opportunity to for impacting and reorganizing teamwork this shutdown, and this has been quite effective in many cases. And of course, new guidelines have been developed by Society for Family Medicine and by professional expert group at a speed unthinkable in normal times. And this is really something applying to telehealth. If you see another results of this use of telehealth during the COVID-19 crisis and the shutdown, what you see, and it comes from a US paper, is clearly three curves. The first curve is the immediate reaction of people or outpatients calling and using telehealth for reinsurance. Then you have the red curve with inpatient using telehealth with the doctors in sync with the severity of the disease and the test of symptoms. And you see a little bit later the green curve, which is a very important curve since I commented on it's the curve related to patients that have chronic disease different from the COVID and that have postponed their care for weeks, for some, for months, for others, with a risk, and that start again using telehealth after this period of time and increasing very rapidly their visit to try to take into account this long period of no care. So if we summarize the most utilized areas of telehealth in terms of such a shutdown, of course, we have the patient consultation, including drug delivery in sync with pharmacists. This is very, very important because if you just do consultation, it's not enough for most. So you really need to have a system that can deliver drug by telephone or with a protocol for confidentiality and for being certain that the doctor is the person who orders the drug. Of course, we have many patients monitored at home, especially inpatients and outpatients, inpatients that were discharged from the hospital and then at home during a period of time that are post-critical and that need follow-up monitoring, and that was done with telehealth. I mentioned the social media and the medical information sharing in time of crisis, just to say that we have probably 3 billion people using social media, and despite the very risk of propagating false information, it is a fantastic tool, and many good initiatives were created during this crisis to propagate good information and reassurance to people for the COVID and what to do and how to share vision of the COVID. And it was very well done in many websites. It's quite important during shutdown to imagine that the medical video conferencing is almost as important as patient consultation. And this is not usually seen as that. It's less considered than patient consultation as a very important item of telehealth. But medical video conferencing is very central. Imagine a country, whatever the country in the world, we have big hospitals, we have also remote hospitals, rural hospitals, small entities that are missing educated specialists in or intensivists. And in that case of COVID, where we needed beds and knowledgeable people in many areas, medical settings, it was a huge chance to get this video conferencing for people who are less knowledgeable, calling their colleague in big hospitals to get information and strategy. Not mentioning at end the mobile telehealth, which is now so important for communicating with all patients. So we learned a lot on teleconsultation during the COVID-19 crisis and the medical shutdown. We learned about the IT infrastructure, the organizational routine and workflows, a lot of actions and strategies that were imagined before have changed with the practicality of doing it every day. Because before, and that will be my conclusion on the next slide, before we were expecting a lot from telehealth, but we were doing very little. And we have totally changed the way we were thinking about these strategies, doing that every day. And this is really one of the major points. And I just want to conclude with deciding that telehealth is a solution to medical access and to medical shutdown. And it's not new by itself. That started in the 40s and was promoted in 2000 by the WHO and required by law in many nations as one of the best solutions for coping with the big changes occurring in healthcare. We have massive aging, much more patients at home worldwide, critical medical demography, so we have more patients and less doctors and nurses in many countries. And we have more and more isolated areas. So telehealth has been recognized as safe and efficient enough and has been recognized as a key solution for coping with this future. But conditions for generalization were not met before the COVID-19. Poor quality of communication, it was also said that it was less effective to proceed by telehealth than to proceed by direct consultation. There was a very big concern about the digital divide and the internet. Also for the professionals about the payment share, because in many countries, just asking by telephone some information to the doctor was not paid. So it was not something recognized as a solution for the future, and the confidentiality was still a problem. So it's true that we have probably imagined a new future with the COVID and this shutdown, because we have developed a solution that have progressively demonstrated that it is safe enough, it's good quality. We have solved in many countries the payment share, and we are now paying for people, and that's the final point that I wanted to say. Medical shutdown, big crisis, but a big chance for telehealth to imagine new solutions. Thank you for listening.